Hey Rebels, doula Robyn Comfort here from the Midwife Calling Podcast that I co-host with midwife Faith Gibson. Thank you so much for tuning in. We hope you're as head over heels for rebel pregnancy as we are. Here at the Midwife Calling Podcast, we have an exclusive first listen for you. It's Faith and me getting grounded together as co-podcasters. It's raw, it's real, it's behind the scenes, pre-podcast release content just for you rebels. So top off that cozy mug of comfort and join me and Faith as we cover some good ground in maternal healthcare and midwifery. And I also share a teaser of my own personal birth experience, and you're here to hear it first. More to come on that. And without further ado, let's do this, Rebels.
Last off, I think that it is very helpful to make a vocabulary distinction between obstetrics and maternity care. Right now, we kind of mesh the two together. We talk about generally maternity care as everything having to do with pregnancy, not so much childbirth. I think of obstetrics as having to do with giving birth, whereas maternity care is prenatal care and postpartum care and stuff like that. But I think that we would be served by having a very specific distinction between those two words. In the first place, the word maternity comes from the word mother, maternal, that it's about providing care to the mother, and that she is the best person to give you feedback on how her baby is doing, because she's with the baby 24 hours a day, 7 days a week. Whereas I, as a midwife, I see the mother for 1 hour once a month or once every 2 weeks or even once a week. But compared to how many hours there are in a week, 1 hour of being in the presence of a midwife does not tell you from the baby's standpoint, doesn't do it. Being the mother, that does do it. So if we make that distinction, that maternity care is something that you provide to healthy women who are essentially healthy and their pregnancies are normal. And obstetrical care is something that is provided to women who have issues. They have medical problems. They have high-risk pregnancies. They've developed a problem that since they got pregnant. That makes it kind of like a clean distinction. And it, in many ways, is what it is that you and I and many other people who are involved in trying to normalize normal birth are trying to do, which is we're trying to get the medical world to think in terms of whether or not they should be providing this kind of care. Do you need to send somebody to school for 14 years in order to take heart tones or listen to heart tones or take somebody's blood pressure or say, how are you feeling? How far apart are your contractions? Do you feel like pushing yet? Those are things that fall into the category of health care as opposed to medical care.
Okay, so differentiating, everyone deserves good health care, but does a healthy pregnancy, healthy mother, healthy baby need medical care? Is that accurate?
Yeah.
According to what you're saying?
And the answer is, if you are all of those things, you're healthy mother, healthy baby, healthy pregnancy, that isn't medical. Nothing in the practice of medicine, which is the treatment of illness, is necessary. That's not going to help you. You're treating somebody for something they don't have, and that isn't helpful. I actually think about it a little bit in the way of the experience that we have as a new mother with a new baby and a pediatrician. So the pediatrician does not come to our house and get up in the middle of the night and breastfeed the baby, change diapers, do the laundry. The pediatrician is somebody that you call or go to see because the baby something's wrong. The baby is sick. And I think about that midwifery care is kind of like that. As long as the mother's healthy and the baby's fine, the fetus is fine, not providing medical care. You don't benefit from medical care. We trust mothers to tell us, as the medical profession in general, trust mothers to know that their baby isn't doing well and they need to be seen. And I would trust pregnant women who are with that baby 24/7 to know if something is not working out right. The baby isn't moving like it used to. I just was describing that the reason for why you pay attention to the baby's movements during pregnancy, because babies, they develop patterns that have to do with where in the pregnancy, like when they're really teeny tiny little babies, you don't feel them move much at all. And then as they get to be in that kind of like somewhere between 20 to 30 weeks, they're still very premature and they move frequently and sleep briefly. They move sleep.
Yeah.
And then as they get past 30 weeks, they sleep a whole lot longer and they move a whole lot more. So you get more this kind of like cluster of moving around, and then the baby kind of like takes a nap. And so when you're paying attention to the baby's movements, you have to kind of know what's normal for this baby at this stage of pregnancy.
Totally.
Again, because the mother is with the baby 24/7, that is absolutely positively the first line of defense in terms of making sure your pregnancy is normal.
Sure. So where would you say that midwives are in providing care, from health care to medical care, on that spectrum?
I think that is probably the biggest distinction between midwives who provide out of hospital, particularly home birth care. That my experience of midwives who are running birth centers is that they really have started to be more about the numbers. How many weeks are you? What was the kick count today? What's your blood pressure? All of those things. And that's sliding into a kind of quasi medicalized, ever slightly medicalized. Certainly anytime that you're attending an out of hospital birth, you're not providing medical care, with the rarest of exceptions. That would be if a mother was terribly dehydrated because she had nausea and vomiting, you might give her an IV. Or if she bled more than what is typical and normal after the birth, you might give her an IV to maintain her body fluids. That and a little bit of Pitocin to make sure she doesn't bleed too much afterwards. That is a list that has got 3 things on it. You look at all of the possible drugs and procedures that one can do. We're talking about 3 things. And most births don't have none of those things ever show up on a normal birth. Most medical, in terms of at least the births that I've attended over the last 10 or 15, 20 years, would be an injection of Pitocin for excessive bleeding. And giving vitamin K to the baby. And also, if the mother is Rh negative, giving Rogam to the mother. And man, that's about it.
Short list.
Very short list. Yeah. So tell me about your experience of having a baby as a person who does labor support for a living for a long time. How was it to be at the other end?
It was honestly nothing like what I expected. I think because I had hopes, wishes, expectations of just a peaceful, kind of mindful birth. And I did so I'll never know if it was like the castor oil effect. I did take castor oil at home. I was coming up onto 42 weeks, so I wanted to get things going. And who knows if that intensified how labor felt for me. And we coach and we talk about the wave, right? You get this build up to the climax of the contraction, or pressure wave surge, whatever you want to call it. And then it comes down. I didn't feel any of that. I just felt like lightning bolts. I know everyone's experience is unique, but it was intense. It was powerful. I was grateful that the water in the birthing tub, the midwife's epidural, I was so grateful for my water tub. It was my favorite spot. And I think one of my, I hear a lot that people really enjoy that transition, not transition itself, but the transition from the contraction sensation to pushing sensation. I was very grateful to get away from the constant contractions to transition to pushing. So it was really intense, but it was powerful. And the longer I get away, my son grows up, he's 3 now. And the longer I have to process and kind of integrate and just reflect, the more just proud I am of myself and my experience and how powerful it was, right? Not just that it was really intense and it was painful and it was nothing like what I expected, but that it was powerful. And I did that. And I did that at home. And it was amazing. Yeah.
I think that is part of what kind of solidifies your adultness. And I think there are other ways to do it. This is one of those things, is giving birth, that you think, man, if I can do that, I can probably do just about anything that Mother Nature or society or life is handing to me, that I have what it takes to do what is needed when it is needed. And it is always,
I agree.
Certainly it was true for me. I was a student nurse before I became a mother.
Right.
Actually had graduated from nursing school by that point, but my instructor, I thought that the sun rose and set. Miss Etta was her name. I loved
Yeah.
Miss Etta. I was so excited to be a student nurse. And when it came to talking about obstetrics and maternity care, Miss Etta was a miss, right? Miss Etta, who had never had any children. And she explained that labor contractions it was just a muscle, and the muscle was contracting. And when muscles contracted, there's no pain. That's not painful. And she'd do this thing where she'd show her bicep and see, make a muscle now and see, does that hurt? And I determined that actually, in a strange, funny way, she was right. The contraction doesn't hurt. It's the expansion of the cervix that hurts.
Ooh, interesting.
It's the stretching open of the cervix. It's a cervical, that's where in other words, it really isn't, the pain is not the fact that your uterus is contracted. The pain is that when your uterus is contracted, it's yanking on your cervix and it's holy shit, man. Yeah, I thought, and I see this with I've provided care to an awful lot of people over the past 25 or 30 years.
Yeah.
There's an underlying sense in many women, and I had some version of this myself, is that the reason that other people's labors were a problem for them, were difficult and painful, is because they didn't do it right. But I, on the other hand, I would figure out what that perfect right was. And I would settle down in that perfect right thing. And then I would get these waves of contractions and I would breathe through them. And then I would rest. And then I would have another. And that is not at all. It's like, it really does make a grown-up out of you real fast. Right. I suppose going through basic training, other things in life that put you on the edge like that, where you can't go back. You can't say, okay, you have the next contraction because it hurts too much. I don't want to have another contraction.
Yeah, not me, please.
Yeah, that's where.
And I
Go ahead.
Like you had asked me, having been a doula attending about maybe 50, 60 births before I gave birth, I had seen some really peaceful women have some peaceful, they were kind of just like hanging out, having their baby. So I guess I had that on one side of the spectrum saying, oh, if it could be like that, how wonderful would that be? But it definitely gave me that expectation that was hard to come to terms with not having that experience. But
did you make a distinction between women having a first baby and a subsequent baby?
That's a really good point, because one of the most peaceful births I attended was her second baby, and this was my first. So are you saying it could potentially be a little softer?
I used to work with an obstetrician who said once you get the first olive out of the jar, all the rest are easier. So if you're having a second olive, in other words, the first time your cervix has never, ever been anything other than closed. You were born with a closed cervix. You spent your entire whole adolescence with a closed cervix. And all of a sudden now you're going, knock, open the door near. And so that's some part of it. But I have seen people have just what I would use the word kind of like miraculous, where they just never looked like they were never in over their head. They were never struggling. They were never holding on by their fingernails.
Sure.
And then the baby just came out. They didn't push real hard. It wasn't a big drama. And that's all lovely. But most of us, I would say 90% of all childbearing women have labor is painful. Pushing the baby out is hard work.
Yes.
And it would be nice if it stopped with pushing the baby out, but then they cry.
Yeah.
And then they want to breastfeed, and then your nipples get sore. Yeah. It's like it's like a horror show. It just keeps on going.
Yeah. The ultimate transformation.
Yeah.
Yeah.
Yeah. It does take a grown-up out of you real quick. And
absolutely.
I cannot help but think about what you and I have been talking about, childbirth, in the context of our current politicalized, where women's reproductive processes and rights have been put under the direction. It's like instead of our own executive function being in charge of our own decision-making process, we have someone who lives in another state or another country, practically, some judge someplace that's in charge of it all. And how to say that there's just really this contrast between what Mother Nature, I'm not going to say we as in society particularly, I don't think society has ever come to a single conclusion about this, but Mother Nature has concluded that we actually give birth through a process that is very difficult. It is painful. It goes on longer than you want it to. It does a whole bunch of things that you didn't like. And yet when you get through with that, I used to, when I did childbirth education classes, is I would start off asking the group all around couples what was their idea of the perfect birth. And if you had 10 people in the room, you would hear fast and easy or fast and easy 22 times. Yes. And then I say, here's what I think the perfect birth, the quote perfect birth, is long enough and hard enough that when you reach down to get the baby or they put the baby in your arms, like that's the easy part. Okay, if I could do all that to get this baby here, I will be able to do what it takes to take care of it and to raise it. Yes. And that is just in the conversation about it. It's like you feel your backbone just straighten up totally. Steely, like that's what it takes to be a parent. I'm not saying that dads don't have steel in their backbone as well, and I think that dads don't need to have some of these same qualities, but
they earn it in their own way.
And then we get surprised. The culture, there's a lot of cultural surprise. Why would women object to the fact that 5 men and one woman have decided that we can't make any decisions about whether or not we're going to an unintended pregnancy, or that we would be forced into maintaining a pregnancy that is desperately dysfunctional for some reason, really something wrong with the baby or something wrong with the mother? Why don't we just roll over and say, oh, whatever you want to do, it's all right with me? So I see that clash between what it takes to give birth without having this process having been done for you by someone else. That is, I keep hearkening back to the bad old days, the dark ages of the Deep South, where we medicated mothers with twilight sleep drugs, scopolamine and morphine during their labor. And then we gave them general anesthesia for the birth, and we did an episiotomy and used forceps and pulled the placenta out. The doctor put a big glove on and stuck his hand up there and grabbed it and pulled it back out. Actually, you have to get it off the wall first before you can take it out. But those women had no experience of giving. In fact, what doctors told women is, you won't remember a thing. That was the highlight of what it meant to be white and middle or upper class in America, was that you could have a baby without ever knowing that you had a baby. And so, how do you reconcile? And women, even if you have an epidural, all that pushing, you have to actually push to get the baby out. And sometimes when women have had epidural anesthesia, they wind up pushing much longer than they would have had otherwise, partly because they're laid down rather than being upright. They're this way rather than this way. It takes longer. The wrong use of gravity rather than the right use of gravity. And also just that your muscles don't work quite right. One of the things that happens with epidurals is that it anesthetizes the muscles that are the pelvic floor. And it actually turns out that those muscles, when they're not anesthetized, when they're able to react the way they're supposed to, biologically programmed to do, it actually makes a funnel that requires the baby to go this way through. In other words, the kid he can't decide that it goes this way because the funnel smushes them in. And when you have an epidural, those muscles are relaxed, and so the baby gets to do all kinds of weird things with his head that doesn't fit down in the pelvis the way it needs to dip down and go underneath the pubic bone. So you can work really hard to get your baby out, even though you were anesthetized, but in spite of that, you still had to work really hard. Took a long time, and with your last ounce of strength You push that kid out just barely. And I think that those personality characteristics are going to be really going to clash with the current, I don't know, it's kind of like a tsunami wave of the idea that somehow or another we should just forget all that quote women's lib stuff, and we should just say yes or no sir, and we'll do our little, what is the handmaiden's tale, put our little kerchiefs on and say yes or no sir, whatever you want sir. I don't think that's going to work out very well. I don't know what it's going to look like, but I for one am going to be right out there in the middle of it.
We have some work to do. I think that's what it is.
Yeah. You know, we talked about on the phone, we talked about topics that would fertile ground, so to speak. That one of the things that I think that this would be a really good conversation to have with people who are childbearing, either childbearing families or childbearing women.
Okay.
That coming to an understanding of what part of the institutional obstetrical care, and that includes the conversations you have with your obstetrician in his office, that there is an imposed structure on the provision of medical care in general, and that includes the provision of obstetrical care, that has to do with doing the thing that to make sure that you did the thing that if you didn't do, you could get sued for.
Okay.
And that is a very different mindset and a very different transactional interaction with the patient than the kind of thing that is typical between midwives and mothers. Although even midwives, there are certain things that if we don't do, we could be sorry for, or if we did do, we could be sorry for. But it doesn't, it isn't the structure. When I say an imposed structure, it's like this, it's like somebody sat down and wrote out like all of these, we'll call them laws, all of the laws for how you practice obstetrics so that you can't get sued. So not only can you not get sued, but your hospital can't get sued because you did something that they're going to get in trouble for. So that's the whole conversation about VBAC and breaches and vaginal twins and things of that sort. It isn't that the individual doctor doesn't feel that he or she was adequately trained and knows how to manage those situations, but that the hospital, if something goes wrong, then you'd be able to sue the hospital, because theoretically the hospital shouldn't have let the doctor do that because their malpractice carrier said, we don't want to fuss around. Just do a nice C-section, get it over with. Which is very nice for them, but it's very bad for the mother who gets the C-section that turns out to basically be terribly complicated and leave her with really permanent damage, or even worse than that, even a fatality. That happens not often, but enough that you can't forget that it's a possibility. So anyway, that would be another little, I don't know, my client that just left said that was a conversation that takes longer than 5 minutes. Because I had it with her.
I think so. Yeah.
Speaking of that, I would like to, and I think that this client that I saw would be delighted to do this. I'd actually like to videotape a prenatal.
Okay.
What is prenatal like when it's about the mother, as opposed to about the structure of ticking off the boxes that you did all the right things and all the numbers came out right, and now you're good. Whether or not she's good, you don't know because you didn't have time to ask. That right now, women's expectations are really low.
I think so.
The statistics are that the average obstetrical appointment, the time spent with the obstetrician, is 6 minutes. I always wonder, Jan, people always say they love him. And I wonder, does he spend more time with them than that sort of statistical average? Is that part of what makes him seem so special? Because if somebody is willing to just be with you on your time, as opposed to their, nope, gotta go now, that would make a difference.
Right. People's expectations are down here and they think that's the norm. Telling them and exposing this other option and the reality of another option of midwifery care is huge on my mind.
Actually, I think that induction is one of those things that we fall in and out of, the idea that somehow or another you're providing a higher level of safety to women by electively inducing them. I find it really incredulous is the word.
Totally. I agree.
Cannot believe. I mean, it comes to me from, I attend normal births all the time. I only attend births where women are not being induced. I'm a midwife. That comes with the territory. I do not hook up IVs with Pitocin in them in people's houses. Obviously, these are women who are healthy, but that's what we're talking about, taking totally healthy women and having them be induced at 39 weeks, as if that is the perfect time to have your baby, is the week before it's due.
Yeah.
And I know that there are statistics that, in theory at least, give credence to that. I believe that the perinatal mortality for the week ahead of the due date is 4 per 1,000. And for the week after the due date, it's 7 per 1,000. So obviously that's almost double. I mean, it's a small number, but you double a small number, you still have a small number, but you still have more than you had before, so you can't ignore the numbers. Then if you go to the week after that, it's 17. Now that's a really big, to go from 4 the week before to 17 in the 41st week. So that's not the due week, but it's the week after the due week, which is when you had your baby, for example. And there are two things about it. One is that I do statistics for my clients based on doing the last 100 births, which is a very easy way to get a percentage, because if you had one of something, you have 1%.
Exactly. I like that model.
Mathematically challenged midwife, this is the perfect way to do stats, because, I had 85 of this. Those were the people who had that's where we're going with this, is that 85 out of those 100 women had their babies before, up through 40 weeks and 6 days. In other words, they didn't actually get to 41. And apparently that there's a relatively, in the last year or two, study that was, one of them was done in Scandinavia, I think Sweden, and the other was done in the UK. That has kind of come to the conclusion that 41 weeks and 3 days is that there's something kind of magic about that. So that would be basically 10 days past your due date.
Right.
That things start really to go up in terms of complications after that, on that 11th, 12th, 13th, and 14th day.
Yeah.
What you and I don't know is if you are talking about a classification of women who are just absolutely normally healthy. So, in other words, typical clientele for the practice of community-based midwifery are women that are so healthy they glow in the dark, so to speak.
I like that.
They shine.
Yeah.
However you want to say it. That because those are the people I see, and I don't see this happening. But then, like I just said, out of that particular block of 100 women, 85 of them had their baby before that 10th day, before the end of that 10th day. In fact, even before the beginning of that 41st week. The issue here is the anxiety that you introduce. I remember when I first started practicing midwifery a long time ago, women would come to me to interview who had had their last baby, where they were supposed to have had their last baby with a nurse midwife. At that time, nurse midwifery was relatively functional. You could still do home births as a nurse midwife before they kind of clamped down and made it really difficult for nurse midwives to do out-of-hospital birth. And the other kind of midwives like myself were not licensed yet, so it's a weird kind of arrangement there. But they wanted to know what would happen if they went over past their due date. And I would often ask, why are you asking? What it is that they had a midwife who dropped them like a hot potato on that 13th day, that their doctor backup wouldn't allow them to attend a birth after past 42 weeks. And these women wanted to know, would that be the case for me? And I would talk about that the issue here was not the calendar, it was the baby. And that figuring out if the baby is still doing well, is still baby moving around, do you still have amniotic fluid, that kind of stuff would be the parameters that I would be much more interested in than the calendar. But also, that was 20 some years ago. Since that time, we do have statistics that at least leave one with the question, are those the kind of numbers that tell us that we are really taking an unwarranted risk by not inducing people before that 40 weeks and 3 days? The last couple of post-date births that I attended, one of them was my own client and the other was as a second call, is that the baby came out with the vernix all over him. And both tested out by, tested the Ballard scale, the gestational age scale, the exam that you do on a new baby. Both of them came out to be somewhere in the 40th week. Their Ballard scale was anywhere from 7 to 10 days off of what we thought their due date was.
Oh, really?
There really aren't any nice, clean, perfect answers to these questions. You have to keep playing the ball where it lies. And a lot of times it lies in enemy territory.
And I really like what you said.
They are going to hang you from the yard irons for having not done the right thing. You both know that the midwives or medical board is breathing down their neck, and they send their cases to me to look at to see if, and I find a loophole in it, so to speak. No, it really isn't the problem that you think it is.
That's rarely. Crazy. So like I said, it was real and raw, really just a sneak peek of what's ahead in the podcast. We hope you enjoyed this Rebel Pregnancy exclusive, and we can't wait to share more of the Midwife Calling podcast with you. In the words of Alicia and Meredith, keep on keeping on, Rebels.